Good morning, everyone. I'm Dr. Yusra Asad. My presentation was scheduled for later, but I will be presenting now. I hope it's been noted.
Yes.
So I'll be presenting on the topic of intravitreal clindamycin as first-line therapy in toxoplasmic retinochoroiditis. Ocular toxoplasmosis is the most common cause of posterior uveitis in immunocompetent patients. Although more commonly self-limiting, optic nerve or macular involvement or severe vitritis may affect vision and thus calls for prompt treatment to maintain vision. It is conventionally treated with systemic medications like triple therapy with sulfadiazine, pyrimethamine, and folinic acid, clindamycin, trimethoprim, sulfamethoxazole, double strength, azithromycin, and tovacone. However, in our case series, we have used intravitreal clindamycin as the first-line therapy for treatment of retinochoroidal toxoplasmosis. The diagnosis of these patients was based on the clinical findings as well as antibody titers of IgG, both IgG and IgM of Toxoplasma gondii. This is our first case. We had a 40-year-old female who presented to us with 2+ vitreous cells, active juxtamacular retinitis, a best corrected vision of only finger counting to 1 meter in the right eye, but a normal best corrected vision in her left eye. On OCT, we found a whole lot of macular edema with some hyperreflective spots in the vitreous and disorganizations of the layer just underlying the lesion. She was treated with 2 intravitreal injections of intravitreal clindamycin, 1 mg in 0.1 ml, 1 week apart, and was started on systemic steroids, tapering dose of 1 mg per kg per day over 6 weeks. 2 months later, her lesion had become sequescent. Her OCT had gone to near normal with no macular edema seen. Our next patient was a 52-year-old female. She also presented to us with 3+ vitreous cells and a focal juxtamacular chorioretinitis. And her best corrected vision at presentation was only finger counting at ½ meter. Her left eye was absolutely normal. As you can see, this lesion here and macular edema, subretinal fluid, as well as intraretinal fluid on OCT. She was again treated with 2 injections of intravitreal clindamycin given 1 week apart, along with systemic steroids. And 2 months later, she had a quiescent lesion with some amount of outer retinal and choroidal atrophy on OCT, and her best corrected vision had improved to 6/12. Yet another case of a 12-year-old male with a small juxtamacular lesion and very little subretinal fluid and macular edema. He was also treated with the same treatment, and his vision improved from 6/18 to 6/6 within 1 month of giving the 2 intravitreal clindamycin injections. The vitritis had resolved and macular edema as well. Another case, 22-year-old male, he had a small juxtapapillary retinitis lesion just inferonasal to the disc with the best corrected vision of 6/9. We also treated him with intravitreal clindamycin, 2 injections given 1 week apart along with systemic steroids. And 1 month later, his vision had improved to 6/6 and his lesion had become quiescent. Just like our case series, we have a lot of studies in literature which support the use of clindamycin in cases of where systemic therapy is either not tolerated or allergic. However, as opposed to that, we propose its use as first-line therapy. The question arises as to why and where. Why? Because intravitreals act at the exact direct site of action. They provide a high concentration in the vitreous cavity. There are no systemic side effects and no reported retinal toxicity in all of the case series that we have seen. However, and the question to where, we can give it to patients who are either allergic, intolerant, or have shown worsening or improvement or no improvement despite systemic medications. And also we have an issue of non-availability of pyrimethamine these days. So how? So apart from this, we would like to conclude that we can consider clindamycin as first-line strategy for toxoplasmic retinochoroides for a multitude of reasons, such as that it is safe, effective, with easy availability, better patient compliance, and improved systemic safety profile, target site enhanced availability, lesser follow-up, and of course, it is a better choice of treatment for pregnant as well as pediatric patients where these systemic medications may not be tolerable. However, in spite of all of this, we believe that further prospective clinical studies are needed to validate its efficacy. Thank you.
Thank you, Dr. Yusra. Any questions, sir?
Yeah, nice presentation, Dr. Yusra. I wanted to just understand your first case. I could not see any choroidal involvement. It was purely retinal in the OCT. If you go to the OCT, and the lesion was not also very classical of a or toxoplasma thing, and there was hardly any vitritis. So was it IgG, IgM positive?
Yes, sir. So we got titers done because the first case to us was also a little confusing. It was a little atypical when it comes to toxoplasmic retinochoroiditis. We did a whole set of investigations, and the IgG titers came positive for toxoplasma gondii.
IgM too? Because
Yes,
G
sir,
can be
but
still positive, you know,
yes,
and
sir. IgM were also positive. Yes.
your second case also didn't have much vitritis. Actually, what is classically seen in toxoplasmosis
Yes,
is a good
headlight
amount
and
of
fog.
vitritis. So that is again that was missing.
Although,
Right.
sir, at presentation she did have vitritis. Maybe the pictures.
Right.
Yes,
Why
sir.
didn't you try to combine DEXA along with Clinda? Why only
So, sir,
Clinda and systemic steroids?
So, sir, we believe there are different studies, and this is debatable. So, dexamethasone, when given intravitreally, one, it has a short mean life, and it may interfere with the action of clindamycin intravitreally. So, giving it systemically would one give a better mean duration of action. Plus, it would let the clindamycin act directly on the target site alone. There are also cases seen of recurrence when giving intravitreal steroids in toxoplasmosis. We had no recurrence at up to 2 years of follow-up in any of our cases.
Thank you. Anybody else?
So it was a recurrence what you had seen in other studies. Is it similar studies wherein?
Sorry, sir, I can't hear you.
I mean, that was the difference between those studies and yours?
Sorry, sir, I'm sorry.
Yeah, what I was asking is, since you have used only clindamycin,
Yes,
since
sir.
other studies used both Clinda and Dexa together, so
Yes,
is it only the recurrence that was the difference, or how faster was the resolution in the other studies?
So in other studies, injections have been given to up to 4 injections, weekly intervals, 4 weeks. We have only given 2 injections. Most of our patients responded very well to just 2 injections, so we continued that. Along with that, there are studies with both recurrence as well as non-recurrence, but the main difference is most of those studies have taken up patients which are either allergic or not responsive or intolerable to systemic medications, whereas we have taken this therapy as a first-line therapy in such patients. It's a small case series, so as yet we have not seen any recurrences. We will continue to give this treatment and see if there are any. Yes, sir.
Right. Have you been following it up with
Sorry, sir. Again, I could not hear
came
you.
the next time? Yeah. Did you follow them up with IgG and IgM?
Yes, sir. The IgM titers had reduced. The IgG were still a little raised, but we did not get a very long IgG titers done because of affordability.